So in this lecture, we're going to talk about what is infertility, reasons for infertility, and things that can be done to help with infertility. So let's first talk about what is infertility. Infertility is just defined by the inability to get pregnant after 1 year of unprotected sex. So if it takes a couple months to get pregnant, that's not infertility. It has to last at least 1 year, and you have to be trying for at least 1 year. It's pretty common. In the U.S., there's about 3 million cases per year, and that equates to about 10% of couples. So very common for infertility, even though we don't hear a lot about it. Infertility can affect both men and women, and so to give you a sort of a breakdown, it turns out that about a third of the time it's an issue with the male partner, about a third of the time it's an issue with the female partner, and about a third of the time it's an issue with both, or it's unknown as to why. And so it's pretty evenly balanced in terms of the causes of infertility. However, the good thing is that even though couples may have infertility issues, due to a lot of the medical advances, they are able to conceive. Now, if we just break down the process of fertilization and what happens biologically for a fetus to grow, infertility, thinking about that process, infertility usually is problematic with one of 4 different steps in this process, in this biological process. The egg must be released from the ovary, and so sometimes that's an issue where the egg is not released from the ovary. Sperm must fertilize the egg, and so obviously if there's no sperm or low sperm count, the chances of fertilization greatly decrease or go to 0. The egg must travel through the fallopian tube to the uterus, so it must make it along its entire journey, and then the fertilized egg must implant into the uterus itself. If it doesn't implant, it will pass right through and leave the body. So looking at male infertility first, there's several reasons why man could be infertile. One is can be caused by structural damage or anomalies in the testicles. A second one is a blockage of the vas deferens, and that's something we talked about before. Vas deferens is this tube that the sperm travel down, the mature sperm travel down to leave the testes, which is where they're made, and be able to leave the body. And we talked about with vasectomies, this tube is actually cut, which prevents the sperm from traveling from their area of production out of the body, and so therefore the sperm will not leave, and a vasectomy then would be successful if that did occur, because then pregnancy can't occur. But even if the vasectomy was not done, sometimes there's a blockage of that tube as well. So whether it's blocked or whether it's cut, sperm is not going to be able to make it from their area of production through that tube. And so if it can't do that, there would then be no sperm in the semen. The sperm could be not viable. So even though sperm are made, they may not be alive. And so that would be an issue. And that could be due to some hormonal issues or disease. Sperm count could be low, at least active sperm count could be low. What's considered a low sperm count is about 10 million sperm per mil. Realize normal is much higher than that, from even 10 or 20 times more than that. So 10 million would be considered a low sperm count. Something that can't be controlled is age. It is a normal physiology for, as men age, for the sperm to become less active and decrease in number. So that would be a normal process. but nonetheless, older men would have much more trouble conceiving than their younger self. Alcohol, drug use, steroid use, all of that reduces sperm counts, and so that would then make it more difficult to get pregnant. Cancers in the reproductive organs, or even certain medications, could reduce sperm count. Again, if a man is on a medication for a certain amount of time, and then they go off that medication, that sperm count should come back up to normal. So it would just be a temporary thing. Same with cancer. If it's treated and it didn't do any structural damage, could go back to normal. So those might be some temporary reasons for infertility, but it wouldn't be long term. Obesity also, and genetic disorders, both of those can also reduce male fertility. This brings us to an interesting syndrome that I just wanted to bring up to kind of talk about some of the infertility issues that men see and how those are overcome. And so in Klinefelter syndrome, and there are several syndromes out there, I just picked this one as an example. This would be a genetic male that has an extra X chromosome. And so men are typically XY, and you can see with this individual they have an extra X chromosome. Usually their secondary sex characteristics all appear male. They have all the male reproductive organs, and so usually this is not even recognized until usually they try to father a child. There are a couple of manifestations that do start coming out at later in life, but usually it's not enough to really send off huge signals, but they typically have small testicles and low testosterone levels. But their infertility, the reason that they have difficulty fathering a child, their infertility is due to a low sperm count or have no sperm count. But if they're able to even have a low sperm count, and this is true of any male who has a low sperm count, they can undergo this procedure. A no sperm count wouldn't work, but a low sperm count they can. And what they do is they go into the testicles and they extract sperm directly from the testicles. And they take those and then they inject a sperm into eggs, mature eggs from an ovary or a mature egg that has released from the ovary. They grab that mature egg and they inject sperm directly into the egg. So we saw a video in our last meeting where eggs were on a petri dish and then sperm were added to the petri dish and the sperm flocked to the eggs, and then there was at least one sperm was able to penetrate each of the eggs on the dish. That's sort of a classical in vitro fertilization technique where the sperm and egg are just added to a petri dish together, and from there nature takes its course. In this one, notice here in this second image in the middle here, you see that the needle right here, which holds the sperm, is injected into the egg, and the egg is held in place by this other instrument right here, probably just some suction device, is what's holding the egg in place, while the needle penetrates into the egg, and then the sperm, which is in the needle, is injected into the middle of the egg, and then from there nature takes its course. So because in a low sperm count you might not get penetration of the egg under classical conditions, you might need this injection system. And right here's an actual microscopy image of this event where you can see the needle in the egg, and I'll see if I can color that in. There's the needle right here, and notice it's more like a tube, just like any needle when you get a shot. There's liquid on the inside and it's plunged in through the needle and out of the needle into the body. And then you can see the suction device right here, which is just probably a little tube that holds the egg in place while the injection is occurring. And this directly injects sperm right into the egg. In fact, I believe this is set up to where only one sperm is in the needle, and so only one can actually get into the egg, because obviously you wouldn't want multiple going in. Now, one thing a physician might do if a male presented with infertility is to check the hormone levels in the male. Remember, hormones are molecules that can control and regulate processes within the body. And so in this case, the two processes we're going to follow here are spermatogenesis, which occurs in the testes, as we know, because that's where sperm are produced. So spermatogenesis just means the making of sperm. And so, of course, that happens in the testes. And the other thing that happens in the testes, another important process, is androgen production, which androgen is testosterone. So testosterone is made in the testes and sperm are made in the testes. And both of those are controlled by hormones, meaning sperm are not made until a hormone tells them to be made. And testosterone is not made until a hormone tells it to be made. And the two major hormones that control this process are FSH, which comes from the brain, and LH, which comes from the brain. So FSH stands for follicle stimulating hormone, and LH stands for luteinizing hormone. So that's what those actually stand for. And again, they're both made in the brain and released from the brain. So on this image, everything from here up is brain. So that's all in the brain. The hypothalamus is in the brain, as it's marked up here. The anterior pituitary is in the brain. Don't worry about the rest of the signals up in there so much. The major things we just want to talk about here is how follicle stimulating hormone and luteinizing hormone control the making of both sperm and testosterone. Now, obviously, an infertile infertile male, its sperm production might be an issue, right? If they have low sperm count or no sperm count, it might be an issue with the hormones. And so if the physician sees that there's low hormone amounts in the male for follicle stimulating hormone levels are low or luteinizing hormone levels are low, medicines can be taken, hormone treatments can occur that would then increase those amounts of those hormones, which would then increase the amount of testosterone and, more importantly, at least more directly, increase the amount of sperm that are generated by the testicles. And so at that point, that can increase the sperm count to that 15 million per mil amount or more that would be considered more of a normal level of sperm. Now, this segues very nicely into anabolic steroids, because now you know part of the pathway to increasing testosterone levels and sperm levels in the testicles. And so many athletes, weightlifters, they want to increase their muscle mass, and one way in which they can increase muscle mass is by taking anabolic steroids. And anabolic steroids are testosterone-like synthetic molecules, and so they act a lot like testosterone. And so your body will use that, and testosterone is a hormone that can increase muscle mass. And so instead of trying to change and make more testosterone, these athletes and weightlifters just take anabolic steroids, they take testosterone, and that increases their muscle mass. But what it also does, it has a side effect to that, and one of those is infertility or low sperm count. And the reason is because even though follicle stimulating hormone and luteinizing hormone increases levels of androgens and sperm, there's a certain amount that it wants to make, but it doesn't want to keep making it once it has enough. And so so one interesting thing is if testosterone levels start to rise in the body, one way your body controls the amount of testosterone is making is that if the levels get too high, what happens is you see these red lines here, and I'm going to change the color of my marker to purple so you can kind of see where I'm talking. But you can, if too much testosterone is made, testosterone will cause the brain to stop making luteinizing hormone and follicle stimulating hormone. It will stop that production because in a normal physiological sperm making and testosterone making, there's a certain range that the body wants to maintain. It wants to be at a certain level of testosterone, not too much and not too little. And so the body thinks, hey, if I'm starting to make too much testosterone, the testosterone itself will go into the brain and actually stop the production of luteinizing hormone and follicle stimulating hormone, which will slow down the production of testosterone and spermatogenesis. What happens with anabolic steroid usage is these pathways of spermatogenesis and testosterone production are shut down. And so your body thinks it has plenty of testosterone, which it does. It's synthetic testosterone, but it's testosterone. So that these pathways are shut down. But one side effect is the follicle stimulating hormone pathway is shut down. And so spermatogenesis decreases greatly in athletes who take steroids, in weightlifters who take steroids, because your body is trying to reduce the amount of testosterone, even though it has basically taken its testosterone production to zero. But because the person is taking synthetic testosterone, your body thinks, oh, I have way too much testosterone, shut down testosterone production, shut down spermatogenesis as a effect of the high levels of testosterone in the body. Even though the body's not making it, it thinks it's making it, thinks it has too much, and it starts shutting down these pathways. And so in these individuals who take these steroids, their sperm production goes very, very low because the body is just telling it not to make anymore. It must have enough. Moving on to female infertility, you'll see that a lot of these reasons for infertility parallel the male infertility issues. For instance, one, just physical structural damage to any of the reproductive organs important for fertilization and implantation would be a problem. So the ovaries, if there's damage to the ovaries, the fallopian tube, or the uterus, there could be an issue with fertility. Much like the vas deferens getting blocked, the travel tube from the testes out of the body, one of the main thoroughfares blocked in males causes infertility because the sperm can't get to where they need to go. And same with the egg. If the fallopian tube is blocked, the egg can't make its way to the uterus, and so that would be an issue as well. Hormone levels, we saw it with men, and how hormone levels might affect the sperm production. Same with women. Hormone levels might prevent ovulation. The body doesn't think it's time to ovulate, so it won't. It might release an immature egg, or it might have a problem with the implantation of the fertilized egg. And so a lot of that's controlled by hormones. Diseases, endometriosis is a big one. That's where the uterine lining grows outside of the uterus, and so has problems with ectopic pregnancies or pregnancies that are or the baby where the baby's growing in the wrong location. It's not growing in the uterus, so that causes a problem. And STDs can cause sterilization or sterility, as well as smoking and alcohol use and drug use. Again, all that and weight gain or loss. So again, that parallels a lot with what we heard with male infertility, and then age, just like we heard with male infertility. As time goes on, the quality of eggs decreases. And we've seen this before, just again showing that as a woman ages, the likelihood of pregnancy drops off. At age 20 to 24, that's a very high level of likelihood of getting pregnant, and then it decreases from that age through the next couple of decades of life, the next 3 decades, where by the time a woman is 50 years old, the chances of getting pregnant are virtually or getting very, very close to zero. One early approach to solving fertility issues is to, and it's non-invasive, it doesn't take any drugs to do, is just actually to chart the fertility cycle for temperature. And this is done in the woman because during the fertility cycle, there's only a short window that a woman can get pregnant, and it's just after ovulation. And so what's interesting here from a scientific perspective is that the body temperature of a female changes in her fertility cycle. Now, most of the time, the fertility cycle is thought to be 28 days, but only about 15% of women actually have a 28-day fertility cycle. Most women are different from that, and so although most charts show a 28-day cycle, most women do not have a 28-day cycle, but that's completely normal. It's just different. So charting temperature, down here I'll just show, again, it's a 28-day cycle, so these are on the x-axis is days, and then degrees Fahrenheit is here on the right-hand side. And notice, to do this, you can't have a thermometer that only reads like 97, 98, 99. You got to get into decimal points, because although in this graph it looks like the temperature following this blue line is very low early on and very high much later, you're only talking about a half a degree difference or so. So you need a thermometer that has decimal points on it, so it gives you a number like 97.3 and 97.9. You got to be able to see those differences. But before ovulation, you see that the temperature of a female is much lower. But as soon as ovulation hits, we get this big old spike in temperature, half a degree or so, not quite a full degree spike. And that's the point of ovulation, and that's the best time to get pregnant, because that's the moment the egg is releasing from the ovary and starting to travel down the fallopian tube. And the fallopian tube is the point at which fertilization needs to occur. And so this gives an indication. So some couples are infertile or feel they're infertile, but it's only because they've been missing ovulation. So one way to increase chances of pregnancy are to chart the fertility cycle of the female, looking for that change in body temperature. Now, because we as humans don't regulate our temperature constant all day long, in fact, our temperatures change throughout the day and between days, it's sometimes hard to chart temperature for when ovulation is occurring, because maybe the jump in body temperature of the woman is not 0.5 degrees, and maybe it's a little bit less than that, and so it kind of mirrors or looks like just a day-to-day change. And so sometimes it's hard to do with temperature with some women. But another test one can do is an ovulation test, and this one and the reason I bring this one up is because it gets into hormones, and so of course, this being a section on hormones, we need to talk about them a little bit. But one hormone, or the hormone that the major hormone that controls the release of the egg from the ovary, is luteinizing hormone. This is the same hormone in males that control testosterone production, and so this is the exact same hormone, but obviously two different tissues. They regulate different things, but they sort of do so in a very similar way. So luteinizing hormones found in both men and women, just like follicle-stimulating hormones found in both men and women. But luteinizing hormone in women controls release of the egg from the ovary. And so by measuring luteinizing hormone, you can get an indication on when the egg is going to be released. And again, the hormone directly controls the release, and so therefore you are going to see changes in luteinizing hormone. So this is a much more dramatic change and a much easier change to see than watching temperature changes. Now, when this luteinizing hormone is released by the brain in women, yes, a lot of it will go down to the ovary and cause release of the egg from the ovary, but some of it does leak into and gets into the bloodstream, which ends up in the urine. And so this test you don't have to draw any blood for this test. This can just be done with the urine by some of the luteinizing hormone that got into the urine and was being excreted from the body. And the increase in luteinizing hormone begins just before ovulation, right, which that makes sense because luteinizing hormone is going to have to be released, has to get to the ovary, and has to cause a physiological change in the ovary before the egg is released. So there is some time between an increase or an increasing in the luteinizing hormone in the urine versus actually when ovulation actually occurs. And so the initial surge and climb of that, as shown here, usually happens just before ovulation, but the peak of luteinizing hormone in the tissues, in the blood, in the urine, occurs during ovulation. And so that identifies the beginning point of ovulation, and so therefore, and now defines the window at which pregnancy is most likely to occur. So again, this test, as opposed to the temperature test, they're both doing sort of the same thing, but the LH test, or the ovulation test, is a little bit more clear-cut than the temperature one, making it much easier for the user to identify when ovulation is actually occurring. I also want to highlight one vitamin that's very important in both fertility and development of the fetus as well. So it serves several roles. And this vitamin is folate. Now, folate's used for other things besides just fertility and development of a fetus. It's used for other things, but I'm just going to focus on those because that's related to reproduction and fertility. And so we'll focus a little bit on the fertility side of it, or the infertility side of it. So it turns out that deficiencies in folate can do a couple things, and one thing that it can do is cause infertility. And so this has been shown in medical studies to show that lower levels of folate are correlated with increasing infertility. Now, in here, notice there's a couple of other consequences of folate deficiency, even if you get pregnant, and that is neural tube defect, which is a problem with the developing fetus, and miscarriage, which is the obviously the connection between the growing fetus and the uterus and the mother. So lots going on there, but focusing a little bit more on the infertility. And what was shown was, and we look at this graph down below, we see that there was a test done between, and they split the women up into two groups. One would get the placebo, and one would get 400 extra milligrams of folic acid. Now, folic acid is a synthetic version of folate. So folate is the natural vitamin, and folic acid is the synthetic version. You can find folate, the natural one, in foods such as beans, orange juice, leafy vegetables like spinach and Brussels sprouts and asparagus can have it. Rice will have folate. But the synthetic versions that are put into some foods like cereals to increase the amount of folic acid that you're getting, so to increase the amount of that nutrient. And so a lot of cereals and breads are fortified with folic acid. They have some probably natural folate, but they also are fortified at times with folic acid. So if you see some packaging that says fortified with and something, it just means that it was added in, and usually it's probably the synthetic version of the molecule. In this case, there's a lot of debate between the natural and synthetic versions, but for the most part, by taking folic acid, you're probably doing fine in terms of getting your amount of vitamin that you need. But nonetheless, in this study, a group of women were given a placebo, and another group of women were given 400 milligrams of folic acid. And this was couples that were trying to just do natural conception, so nothing, no more scientific intervention, but this taking the folic acid. And the group of women were women who were thought to be subfertile. And so this was women who were maybe struggling a little bit, or couples who were struggling a little bit to get pregnant. So they did that. And notice that in 3 months, over a 3-month time period, there was a 2.5 time improvement on women who took folic acid, the supplement folic acid. And so this highlights that the chances that infertility in part could be caused by folic acid deficiency. Now, it's possible some of these women didn't have folic acid deficiencies, and and whether it be in the placebo group or not. But nonetheless, it looked like increasing supplements with folic acid did help. And even today, women who are trying to become pregnant or are pregnant, one of the things that's always prescribed by physicians is folic acid. So that'd be very common to get, partly because the developing fetus needs it, and partly for those on the struggling getting pregnant, sometimes that could be an issue as well. Now, there are a lot of reasons for infertility that we didn't discuss. Some are things that are important, and some have less importance in terms of if infertility will be caused by these certain reasons. The boxes that you see in these columns just kind of talk about the severity, or the more important risk factors are the ones in sort of this reddish orange. The orange ones are kind of lower than that. Yellow are less important, and the blue is not a problem at all. So, for instance, if you look in one of these blue boxes here, if you're under the age of 34 and you've been trying to get pregnant and haven't been able to for 8 months, that's not thought to be infertile. That seems very normal. You don't really need any outside intervention at that point. It's going to have to be more than a year before any intervention beyond what you've been doing is necessary, before it's thought you're infertile and maybe need some extra help. Other things that are kind of have some slight risk for pregnancy that might cause some problems. Nicotine is an issue. Stress, we didn't talk about stress, but more stress reduces the chance of pregnancy. Again, a lot of this has been shown in studies. We talked about alcohol. Caffeine can cause a problem. Marijuana can be a problem as well. But those are all lower risk problems to infertility, not high risk. If you look down at high risk, we talked about the problem with steroids. We didn't talk about with Class A drugs. So some of those Class A drugs would really mess up the reproductive system enough to where infertility would be an issue. Concern starts to hit if it's been more than a year of trying as well. And then there's a few others in between that we talked about some of them, didn't talk about other ones. But you can look at this list. You don't need to memorize this list specifically, but just have a general sense of some of the risk factors or things that might increase the chances of being infertile. Now, if ovulation tests didn't help trying to predict ovulation and hormone treatments don't help, there's obviously more innovative approaches to fertilization. And so I'm just going to talk about one of them, not getting too much into detail, but just mentioning how it's done and what it is. But in vitro fertilization, we've probably all heard of the technique before, but just to be clear on what it is, this is all this slide is going to show. Essentially, what happens when couples want to go under in vitro fertilization is the female is given hormones to stimulate egg production and maturity of eggs and release of eggs, and then surgically the physician goes in and gets eggs from the ovary. And so that's shown here. So we need to grab some eggs. The male provides sperm, and both eggs and sperm are processed. We're not going to go into detail of how that's done, but then they're put into a petri dish. We saw this in the video where the eggs were on the petri dish and then the sperm were added, and you can see the sperm moving towards the eggs and attempting to penetrate the eggs. We saw that envelope was formed around the eggs once the fertilization had occurred. And then, of course, you can see here the eggs start to develop, and you can see that it's no longer single. The egg is not a single cell, but it starts to multiply. And so in these images, each of the eggs or embryos at this point, because it's a fertilized egg, has 4 cells in it, but that will obviously continue to increase. And then what happens is that one of these eggs is implanted into the uterus, and the other eggs would typically be frozen for use down the line if needed. And so if the egg implants into the uterus and will begin to develop normally. So obviously techniques like this can be done as well to help with fertilization if the problem isn't with the uterus lining and it has some problem other than that. Obviously, if there's a problem with the uterine lining, you can't implant it back into the woman if that was the issue. This wouldn't work, but for a lot of the other reasons, it would work just fine.